Hello everyone, I didn't see all of you this morning. I hope you have enjoyed your social dinner. And we arrived at the last plenary of EHMA 2025. This session is on a very serious topic because it's on new financing and payment mechanism to enhance health system performance. And without further ado, I would like to introduce the facilitator of this session, Dr. Matthias Wismar. He is Program Manager of the European Observatory on Health System and Policies, and the Observatory is a long-standing partner of EHMA. He is a long-standing partner of EHMA. Matthias, the floor is yours.
Thank you so much, Catherine, for the kind introduction, and welcome to the third plenary. And before I give a bit of an introduction of the topic we will be discussing today here at the panel, I would like to put this plenary into perspective of this amazing conference, because we actually started with a plenary on from reactive to proactive, shaping future health systems. Federico, you were part of it. It was really about health systems transformation, that we need to have foresight, look forward, and probably do sometimes a little bit bolder steps. And then the second one, I see Olivier over there, was about innovation, and we were discussing different sorts of innovation and how they can actually contribute to health for all. It was technical innovation, it was organizational and other innovation. And now, as a consequence, we delve a little bit deeper into it, and we are thinking about, how can actually finance mechanisms, how can they support all these innovations, how can we innovate it? And in technical terms, we would, wrong page. In technical terms, we would talk about value-based payment, because that is the perspective. We don't want to pay anymore just infrastructure, the numbers of beds, or we don't want to pay only procedures, how many visits somebody is doing or how many things have been performed. We want to pay for value. And of course, there are plenty of different definitions what we understand for values, but we, as the observatory, we always use a health systems performance assessment framework, and then we are talking about outcomes. We want to pay for better outcomes. We want to pay for better patient experience. We want to pay for better access, for quality, for safety, and also to some extent actually for financial protection. So we have clear outcomes, and intermediate goals that are linked to the value-based payment mechanisms. And in concrete terms, sometimes it's bundled payment mechanisms, sometimes it's pay for performance. In any case, they hold big promise, because people believe, and many researchers believe, and on the conceptual level, it's all true. Value-based payment has the capacity to reduce unnecessary care, And I think this is very important. Pamela, we were this morning in a workshop on greening health systems, and less unnecessary care is actually a very good strategy, to avoid diagnostics, which is very intensive in terms of energy consumption and so on. So reducing unnecessary care, increasing productivity, we're always talking about performance improvement, we want to at least maintain the performance of our systems, but even better if the performance is better. And also, very interesting for payers, the financial risk is actually moving from the payer to the provider, and the provider is held to account, about the cost, the quality, and all this. And there's another topic which is very important for those countries which have health insurance systems, Health insurance systems are, by definition, very often fragmented. And the payment systems we are talking about today, the value-based payment systems, they hold the promise that they help to integrate, that they bring together the different services, that they avoid micromanagement, and that they probably also provide for a better patient experience. So that's all great. But there's one more element I would like to add to it. I mean, we've been just talking about greening health services, you know. Health systems are really big and they have big impacts, you know, on all other policies actually, you know, whether it is labor market, whether it is gender equality, whether it is the environment. And we want to discuss also whether it is possible to integrate other policies objectives into value-based payment systems. And sustainability is, I think, a topic which is highly relevant for many of us. So, I'm almost through with framing the panel discussion, but I would like still to say a couple of words about our panelists. We have as a keynote speaker today, Scott Greer. He's professor at the University of Michigan, but at the same time, he is senior expert at the observatory. Scott, fantastic to have you here, very good. And you already probably wonder, oh, we're talking about payment system, but Scott is a political scientist, and we did it on purpose. You know, we did it on purpose because I think very often the challenge is the implementation, the acceptability, you know, and I think that a political scientist may have here actually a fresh and realistic perspective on the topic. Second, it's my great pleasure actually to welcome Beatrice Duvet. She has a PhD in pharmacy and she is a research fellow and she has researched extensively in Europe into the topic, so we will be very interested to hear from you and to fill us in a little bit on the evidence and what countries are doing. And you know, I hardly need to introduce you, Federico, because you're not only a professor of health management and policy in Milan, but you've been also, you're past president of EHMA. You've been very long president, and you're kind of EHMA bedrock, actually, so to say. you're always around. You have, I saw on the chair there was your name, you know. So like that was very okay. And last but not least, I'm very happy that Pamela Mazzucato has agreed to join this panel. She is assistant professor at the Karolinska Institute, but at the same time, she's actually in a hospital, the director of research and development and innovation. And this is a perfect fit for this panel because she brings not only the academic perspective, she does not only know about innovation, she's also, in a way, a practitioner actually. So thank you so much for joining us, and I'm really looking forward to this panel discussion. Just to let you know, we will have 2 rounds of questions here and input from the panelists after Scott's presentation. And then my colleague Nathan Schuftan and me, we will go around with microphones and collect a couple of questions from your side that you can fire to the panelists. So thank you so much. Scott, floor is all yours.
And thank you for the kind introduction, and thank you for being here after a lunch on a Friday afternoon in a wonderful city. I had a rather sour colleague once who evaluated payment systems, and once he summarized his life's research to me as, the government did a thing and it didn't work. I didn't like him much. He's some other university's problem now. I'm also happy to report that in preparing this, I learned that he was wrong. That feels even better if you're a professor. So I'd like to present some of the basic ideas we have in the innovative payment systems, or alternative, or whatever you wish to call them, and then the results from a lot of evaluations of a lot of experiences across Europe, Canada, and so forth, and then talk through a couple of the issues that arise when we're trying to think about both their adoption, but also how to make them work in health systems. So to begin, what do bundled payments and adapted capitation and shared savings and pay for performance actually have in common? Are these just different names for the same thing? Are they totally different concepts that mean we should pay different consulting firms each time we adopt them? Well, there's a negative definition. It's what they aren't. The first thing they aren't is payment for activity, right? We all know what payment for activity is. We pay you every time you do a knee replacement, and we thereby incentivize you to do more knee replacements. They're also not payment for inputs, right? They're not payments for example, hospital beds occupied, or simply to hire more people. So that's what they aren't. And there's a certain power in that because there's a lot of health systems that 20 years ago were built on that kind of payment. And payment for activity is still probably the norm. The positive definition is that they're supposed to be payment for value, right? So they're supposed to be something that actually relieves the patient, actually improves health in some way. So the government is not buying, or the payers are not buying simply activity, they're buying activity towards a desirable end. Ideally, it's good quality activity. Ideally, it's done as efficiently as possible. Notice how this is already starting to get a little bit woolly, right? Because the problem with these payment systems is that they are very, very susceptible to somewhat tendentious, weak rhetorical definitions, right? So start with the usual trick in healthcare, which is whenever anybody proposes something, think about the alternative, right? So what's the alternative to value-based payment? Something like valueless mismanagement? In other words, when you name it value-based payment, you're already boxing the audience into agreeing that it's a good thing. Equally, one of the themes to look for in this literature, and part of the reason that it was good to get to do a big literature review, is that there's really often a mismatch. Philosophers call it the Motte-Bailey problem, where the study is a nice tight study of one service line in one region of one country, and the conclusion is that bundled payment is fantastic and the whole world should adopt it. And you see a lot of that in this literature. One nice tight evaluation of one very small program converted into a claim that the whole world's problems are going to be fixed if we all adopt the innovation. So you want to be careful. Those caveats in place, we have a lot of research nonetheless, and it's not a bad set of outcomes. The goals are often achieved. If the goal is to reduce bed occupancy or length of stay, frequently it does that. If the goal is to reduce readmissions, frequently it does that. Not all of the implementations of payment model reforms have produced all of those things, but these are all things that if you make it your goal, there's a decent chance that you can find an available payment system that's going to produce it. Looks pretty good so far, right? Reducing lots of things we don't want and improving lots of things that we do want. Do notice, however, what the goals aren't that we're noticing, right? We're not seeing, for example, environmental sustainability. There's a lot of effort going into things like social supports and social prescribing, but that's really hard to build into a payment structure. So many, many good healthcare efficiency outcomes. The weakness is often when you're trying to produce something other than efficient quality healthcare services. Now, better still, I'm a political scientist. Unintended good things, that's not my natural language. I study politics. But we also found unintended benefits, and these are from a set of studies that, in addition to what they were trying to achieve, they often found that the policies produced other good things. Longer visits with the doctor, because if you incentivize quality and care coordination, one of the best ways to do it is to have more than a typical 7 or 8 minute primary care appointment. Better care coordination, again, if you're incentivizing quality, trying to avoid readmissions, improve patient satisfaction, well, it turns out that better transfers to step-down care is a great way to make patients feel better. It empowered non-medical staff, many of whom like that. It increased utilization. Unexpected benefit, but it's one that we've seen. It turns out that if you pay people to increase quality, sometimes that means they get more health care. Please note that an unintended benefit from our point of view might not be an unintended benefit from the point of view of the finance minister. Increased utilization is not a phrase that is going to make you a lot of friends with the Treasury. Now, the thing to think about, especially on the unintended side, is the organizational changes that the policies enabled, right? Because there aren't that many single-handed doctors out there in a practice of one. Very few. What there are complex organizations, hospitals, partnerships, clinics. So a payment system reform, if it is to be successful, has to incentivize the management of the organization to make the changes that are actually going to produce the result. So it incentivizes managerial behavior. It doesn't directly change the process of healthcare. And, as I said, value for whom? Because we might be interested in better value, but better value might cost more. You've all bought something that was too cheap and broke immediately, right? Better value can cost more. You can get what you pay for. And again, that's not music to the ears of a typical finance minister who thinks we already spend plenty. Now, it's not all good, right? And there's kind of 4 clusters of things that go wrong. One is perverse incentives and selection biases. So if you create a voluntary program that providers can opt into, the providers who opt into it will be ones that either are already achieving the goals or are very close to achieving the goals. If you make it voluntary, people who are going to fail won't join. Individual services will often select in or out. So we hear great things about care integration in some city, and then we learn it's actually care integration in the stroke services, and we have no idea whether arthritis is any good. And the patients can select in or out. You can create financial incentives for patients to do things. For example, change the structure of primary care towards gatekeeping with some incentives, and that's going to give you patients who want the incentives and are untroubled by gatekeeping. Well, I like that group more than the ones who have 3 chronic diseases, ignore the incentives, and want to keep their doctor. So a lot of gaming, a lot of perverse incentive problems. We'll come back to that in the question and answer, I believe. There's data and there's administration problems. This depends on collecting a lot of information. Think about something as simple as hospital readmissions. You have to have a very precise understanding of ICD codes, and you have to keep good records in order to say this patient was readmitted, right? If the orthopedic patient is discharged on Tuesday and they're back in the hospital with an orthopedic problem on Friday, you can bet that the orthopedic surgeons are going to say, different problem. You know? You can create small biases in data systems that are very costly for providers. So, for a minor example that I particularly treasure, when they first introduced the QOF, the Quality Outcomes Framework in NHS England, they had no age restriction on things like calling people for breast cancer screening. So every English GP could tell you about how their secretaries enjoyed phoning people up, a 90-year-old person with congestive heart failure, and saying, your doctor really wants you to come in and spend a whole day getting a breast cancer screening. Right? I'm not a doctor, but of all the problems you have when you're 90-year-old and have congestive heart failure, breast cancer screening is not the solution. That leads into the professional costs, right? A lot of times professionals will perceive any change to payment systems, regardless of what we think, as a loss of professional autonomy, right? It's some other person telling them what is value-based care. Most people like to believe that what they do is valuable, right? They also have to pay the administrative and data burden. In some of the most IT-intensive health systems, the standard of care for a birth attending is 2 nurses. And as far as I can tell, 1 nurse attends the parents, the kid, and the other nurse attends the computer, right? It takes an enormous amount of professional time as well as IT consultants and equipment to gather the information that we need to implement fancy payment systems. And they don't like it. Hands up among the healthcare professionals if you went into this field because you want to do data entry all night. Thought so. Also, bear in mind, increased efficiency can mean reduced satisfaction, right? If what we achieve is reduced length of stay and more intensive treatments in hospitals, think about what that does to the hospital staff who no longer have any easy patients. Right? You can find yourself on this escalator of increasingly acute patients with increasing problems, and as soon as any patient gets a little simpler, out they go. Efficiency achieved, staff burned out. And the final one is care costs. Like I said, delivering value sometimes costs more. So you can get higher utilization. If we pay to avoid readmissions, frequently you can avoid a readmission by keeping the patient in the hospital for another night. Longer visits, when we go from an 8-minute primary care consultation to a 16-minute primary care consultation, we've cut the number of patients that day in half, and that's even before we add a lot of time doing notes so that we can get our quality framework incentive. And longer stays in hospitals. So these are unintended or undesirable from at least some perspectives, right? If what we're trying to achieve is efficiency, then value might not actually be what we want. And I want to underline, we're very, very bad at costing the effects on the professionals. We're very bad at costing the consequences, psychological and otherwise, of professionals having to enter all this data and be told that they're supposed to achieve this goal, right? Do you want to be the practice nurse who calls up a 90-year-old with congestive heart failure and says, come in for your cancer screening? That's not what you went into nursing to do.
3 minutes.
Yep. So here's some things to think about. The first is we call them innovative. I'm sorry to undermine the beautiful Emma slide. A lot of the time what they are is difficult. They're difficult to implement. They are known concepts, but working your way through all these problems takes effort, and then having organizations respond to the incentive takes effort in the healthcare organizations, which is something to always remember. You can aim an incentive at an organization, but if the managers can't respond, if the workforce won't have it, okay, game over. The costs matter, right? And they can change system structure. The United States is a galaxy of these schemes, and one of the results is that it's become very, very hard to manage a medical practice. You don't just need IT, you need people with postgraduate degrees in basically American medical payment system studies. Along comes private equity and says, we will buy your practice and solve your administrative problems and you can do medicine. In the short run, it's great. You have money, you do medicine. In the long run, guess what? You work for private equity now. And we're starting to see this model coming into Europe, and complexity enables it. There's a race that I think we'll discuss in Q&A, which is on one hand, as we know, it takes about 3 years for any organizational change to potentially become efficient, right? The first effect of any reorganization is a loss of efficiency. And it takes about 3 years to get to efficiency again. On the other hand, it takes maybe 5 years for the providers to game the system and for the incentives to stop working. So you can imagine a cycle of constant new policy. And then I want to end with one thing. You know the Pareto principle, right? 80% of most problems are pretty easy to solve, right? 80% of your house is easy to clean. The lamp fixture 3 meters above your head is hard, right? 80% of the time you wear 20% of your clothes. In healthcare, what this means is that 80% of your patient flow is pretty regular and manageable, and we can build a payment system on it, and 20% is hard. In the private sector, you ignore the 20%. I do not want to go out of my way to get complicated, expensive clients who cost a lot to handle. In the public sector, in services with a social vocation, you can't ignore the 20%. And that means that scaling is a big problem, right? We get it to work in one region or one section of primary care or one hospital or one service line or one country. We still have a really big question as to how to scale it, how to scale the evaluation, what have we really learned, and also how to scale the policy. So these are some things to think about because I couldn't bring myself to leave you with nothing but happy news. But the takeaway is that these are all manageable. It's not a silver bullet, partly because value-based payment is not one thing. But on the other hand, it seems to be a key and constantly renewing part of the effort to deliver value in healthcare systems. Thank you.
Thank you so much, Scott, for this big picture, the panorama on value-based payment systems, and also for being so very specific and detailed on the benefits, but also on the downsides and on the dangers. And actually, even though in the middle of your presentation, oh my God, where is it going? You know, am I on the wrong panel? Then I saw that you already provide us a little bit of a perspective. Actually, you know, it's really about the implementation, you know, and the kind of skillfulness how you implement it, and also to some extent actually the expectation management. You said it's not a silver bullet, but it's something which we need. And I was just talking to Pamela. Actually, we were talking about payment mechanisms in hospitals. You know, some people are very dissatisfied with the DRG systems. diems in some countries, but then when you think back when we had hospital per diems, how bad this system actually was, then you think, oh my God, maybe it's even better. We just need to tweak, to improve, and to move to the next stage. And to understand where we could move, we have today Beatrice here on the panel, because she has researched quite extensively different models in different countries. And Beatrice, just give us a little bit of an overview what's concretely happening in the countries. We've heard from Scott the conceptual stuff, and now we get a bit of a European perspective. Floor is all yours, please, Beatrice.
Thank you.
Otherwise, take mine.
Yeah, maybe. Thank you. Thank you, Matthias, and thank you for the opportunity of being here and sharing this piece of research that was led by our colleague Ruth Weisberg from the Berlin hub of the observatory, and plenty other colleagues also participated in this research. So we worked on a comparative research paper on value-based payments, and there are many countries that have been using value-based payment models. So we selected 5 countries that are a varied sample of high-income countries that are representing different models, and so we selected Canada, the Netherlands, Germany, the UK, and in particular England and Sweden. And what we did is that for each of those countries, we did a rapid review trying to map a bit the types of value-based payment models that they had. And we identified 25 models, and then we selected 11 models that seemed to show a nice variety of models to study further. And we then interviewed experts for each of those models. And so this is how, with a mix of literature review and experts' qualitative information, we have been able to get to know a bit more about those. And as Scott highlighted, value-based payment is a quite generic definition. It's not only one thing. It can be declined in multiple models and with multiple purposes. So across the selected models, we saw some population-based payments, or capitation, episode-based bundle payment, shared saving agreements, pay for performance, pay for quality. Some of those models were having a mix of different value-based payment models, and also a mix with more traditional payments such as fee for service. And the objective also differs, and we could see maybe 2 groups of countries. So one with Canada, Sweden, and the UK that have more NHS systems and that had more a top-down approach with value-based payments that were initiated by the national or regional government and then applied to all the providers. Whereas we had the Netherlands and Germany that have more national health insurance systems, and where here it was more of a bottom-up approach with value-based payment models resulting from payers-providers negotiations. And so this also then transpired in different objectives. So even if sometimes the models were the same, the objectives differed. So for the first group, these countries have service delivery that is already fairly integrated. So here the objective for the UK, for example, was to really improve quality of care and reduce unwarranted variation of quality of care. For Sweden, it was to foster public-private provider competition and also increase quality of care, while in Canada it was to recruit and retain GPs so that it would increase accessibility and availability to primary health care. In the other group with the national health insurance countries, here, however, intrinsically, the countries are more fragmented, and so here the main objective was more around care coordination and integration. And so overall, the objective was to increase value by increasing the output. However, in none of those, for none of those models, the objective was to reduce costs. And I think that's also an important point.
Excellent, thank you so much. Can I ask you something? I mean, we are talking about innovation, and I think in terms of value-based payment mechanisms, it's not the novelty. The innovation is if it is really implemented and it's changing things dramatically, so to say. But when did countries actually start with this sort of value-based? Do you know anything about it?
So indeed, it is not new. For those 5 countries, we had countries starting over 2 decades ago, while others have been implemented models in 2023. So it's really spread different, between countries, but indeed it is not new in the European space.
And can I ask you something? I know you have not been involved in the interviews with experts of all countries, but when talking to them, what was the kind of sentiment you felt? Were they were they a little bit exasperated? Were they a little bit frustrated? Or were they enthusiastic about their bundled payment mechanisms or P4P?
Well, indeed, I haven't been involved in all the interviews. I've been involved in the one for Sweden, and they seem overall happy with the models, even though they, of course, there's always things you could do better. But I think those interviews were also really interesting to put some qualitative elements to the literature that we could find, and it was also really nice to have their perspectives and what sparked the most from them through these interviews.
Thank you so much, Beatrice.
Thank you.
Federico, I would like to turn to you now. And you know, when preparing this, we thought, Italy, this is probably ideal country for this kind of thing because you have very decentralized health systems, and unlike other federal countries, they differ actually, the health systems in Italy. Do they also differ in the use of payment systems? And if so, is it a kind of natural laboratory here in Italy? So what is happening in Italy? What's the state of play?
Thanks, Matthias. How much time do I have?
Oh,
It's a tough question, so I'll try to make it simple. It is a laboratory. The 20 regions are trying to experiment different ways of funding, but we have a main mechanism which was set by law back in the mid-90s, which I think might be of interest for everyone because it's based on 2 principles. The system is organized into local health authorities, and local health authorities are running integrated delivery system from hospital to primary care to preventions, and they're funded by capitation, adapted capitation. Basically, the weight is based on the age of the population, but it's capitation. We want to call it value-based because capitation doesn't really has nothing to do with values. Just about this is the resources you have, and you have to do it with it. Then what we did, we connected capitation to a system of kind of pay for performance. So we say to the regions and to the local authority, because both the regions and the local authorities are funded through capitations, that they have to be accountable for specific performance. So we set up a dashboards of indicators, of measures, which they connect with value. They have to do with clinical pathways, they have to do with waiting lists, they have to do with accessibility, they have to do with adherence to specific protocols or guidelines in terms of best practice in clinics. And 1%, not very much, but 1% of the capitation is connected to that specific achievements in terms of index at the regions level. And then the regions are free to experiment any type of further variable, let's say, making variable capitation for the local authorities. There are regions that are pushing that forward. They say 10% of your capitation will depend on the result, others are less brave. Contemporary, we develop a second funding system for the independent hospital. In Italy, the large hospitals are independent because we thought at the time they needed to be competitive, so they needed to be running, basically, and we introduced the DRG system for those hospitals. So now the system works in this way. The local authority has the capitations, contract with the hospital, the global budget based on the DRG system, but we set up very quickly cap, because we know that otherwise hospital through a DRG system can become cannibalizing machines for treatments or for cure. So they have a global budget, and the global budget is again connected to a specific set of penalties and rewards based on a dashboard they have to reach, which again goes back part to value, because now we introduce a national program for outcomes, and all hospitals are measured against a number of outcomes they're expected to deliver. They're not really outcomes, often they're proxy, like now you have to do certain intervention in certain times, because that's actually what the clinical protocols or the best practice tell you to do. You have to, for instance, start measuring prems and proms in order to make sure that you move in the culture in that direction. So we thought that the DRG system will actually help us to make the independent hospital more competitive on one side, more efficient, but on the other side, we need to actually to balance that with a counter system which say, okay, you can run as much as you want in terms of productivity, but there's a global budget, so an over-treatment and control. So I think it's a good laboratory if you want to see actually how can we actually run a system spending on average 1/4 less than many other European systems and still doing good. So that's the
Federico, can I ask you,
yes.
Do all the regions do the same? They are all innovating the same, or are there differences?
No, there are some differences, obviously. There are some regions which are trying to, there are, for an historical reason, they are more prepared, I would say, to run innovation. So obviously we have a divide, south-north, and sometimes east-west, like east-west, like in many other countries. There are at least 4 or 5 regions which are leading in that sense. We also have, just really quick, because some of the regions were in critical financial conditions, they were kind of commissioned by the national government, so those regions are not really authorized to do a much innovation. They are under control, but the other, they're moving forward, and we, just to conclude, there are regions that are introducing bundle payment in 2 ways, basically. One is, we call them extended DRG. So now we have DRG including also the community services which were necessary for the patients for rehabilitation, so for follow-up. So the hospital is integrated in the sense that they have a common scope. And we have what we call macro activity, complex macro activity for outpatients. So when we know that patients will require over a certain amount of time a number of services for the chronic conditions or for the assessment whether he needs or not to get to a certain procedures, they can be combined together and they're paid in one single bundle payment for the providers.
Federico, can I ask you, how do providers react to it? Because the way you are explaining it seems to me quite demanding on the providers, you know? Yeah. They need to deliver quality, they need to deliver value. Yeah. At the same time, they have caps. So, and then they need to do innovative things like reaching out to community services. How do they react? Are they overwhelmed? Are they mad at you?
They're really under stress. They're really under stress in many situations. But again, it goes back to, and that's something maybe we can discuss later, Matthias, is the governance that actually really make a difference. Our system is an NHS, so there's obviously a dominant role of the public authorities. General managers depends by the local authorities. They have a spoils system with the region, so they will complain, but not so openly as they would like to do so. And some of the private providers are created within the system. They did some resistance. They're trying to lobby sometimes against some of this. By the end of the day, they have to accept it because that's the way the system says.
Very good. And indeed, we come back to the governance in the second round.
Yes.
But before that, we want to be filled in a little bit on the situation in Sweden. Pamela, you've done quite some research on adopting value-based payment systems in Sweden, and they're very interesting examples. So please.
Yeah, well, I've done some research on value-based healthcare, not only looking at the reimbursement aspects, but rather looking at redesigning healthcare organizations tied to that. But the research that I'm familiar with is tied to some of the examples that you've also studied. We have experimented with bundle payment for hip and knee replacement, for instance, when there has been basically providers are reimbursed with a lump sum, and in the lump sum we also included the cost for possible complications post-surgery. So the idea was to incentivize efficient and good quality of care. So if a patient would be discharged and then readmitted because of complications that could be associated with the surgery, then the provider would not be reimbursed extra money. And that experiment has been successful in terms of reducing waiting time and also improving efficiency. But as many of us have also discussed already, I mean, reimbursement models are not part, I mean, you can't consider them in isolation. They're part of a larger system, more complex system, where different mechanisms come into place. So one positive outcome on one respect could have unintended negative outcomes on other respects, as Scott illustrated very well in the beginning.
So what were they?
Well, for instance, I mean, the bundle payment or value-based model was experimented in the context of a patient choice reform. So in Sweden we have had, like, at least up to today, a lot of the governance has pushed a lot for competition as a mechanism to improve efficiency and also quality. And we're kind of rethinking that. So I would say, I mean, the bundle payment in the context of a patient choice reform has also led to unintended consequences, such as, you know, having some providers focusing only on more simple cases and then leaving the public hospital with the more complex cases. It has also created complications for the research and education system. So we have observed a number of unintended consequences, and now we are focusing much less on competition and try to strengthen instead the collaboration within the healthcare system.
Scott, I feel there's a message emerging from the panel. Beatrice tells us, oh, this goes on in some countries for decades, actually. You know, they are still working on it. We hear from Federico, yes, we go forward, we do really innovative things, but it's hard and not everybody is pleased by it. And we hear also the complexities, you know, from Pamela all around it, you know. So do we need to have some expectation management when it comes to a value-based payment system, that people understand, yes, it's worth it, but it's quite complicated and it's not, as you said earlier, a silver bullet?
Absolutely. It's not a silver bullet. It's almost a management problem in itself, which is that you're necessarily paying providers to do work. Like that's kind of what health systems do. So the question is, how do you do it, and how do you manage the various incentives that it creates and keep them from being contradictory, allow them to respond to population needs and desires in some way, avoid too many perverse incentives, and of course deal with the fact that after a few years the providers will have figured out how to game it. So you might have to change it simply in order to gain the efficiency values that you were initially looking for. So it's not like there's a question with an answer and then we're done. It's a policy problem.
Thank you so much, Scott. Beatrice, can I come back to you? And the question I would have for you is, I understand that the focus of the research was to understand what countries are actually doing and how they are using it. But do you also have a little bit of an idea about the effectiveness of it? You know, to what extent those who have commissioned it, you know, the governments or the payers think, oh well, that was actually worth it. It has worked, or it has at least produced more on the positive side than on the downside, which we heard. Do you get from your studies, do you get some sort of a feeling of this?
Yes, so we also indeed try to look a bit at the outcomes of those models, and I have to first have a big disclaimer that there is not one single answer. I think it's very, very context specific. It depends on the type of value-based payment models that has been chosen and how it has been designed. And as you mentioned, there were many changes across time, so it all depends on what you're looking at exactly. Here for those 11 models, we saw that around half of them have been formally assessed. Some others had it was a plan for assessment or ongoing, so we try to look at this, and again we try to also have the qualitative input from the experts. Overall, it seems that most of those models have achieved their objectives, at least partially, maybe not in full, but at least part of the objectives. If we're looking at improving integration of care, it seems that those models are relatively successful on this point, as the ones that were aiming for this saw some improvement, but also the ones that had different objectives also saw improvements in care integration, and notably an increase in patient-centered care and more meaningful patient-providers relations. If we're looking more at cost and efficiency, as I mentioned, for none of those models, the objective was to reduce cost. And on some it hasn't reduced, but it hasn't increased either. And so maybe here it's a bit about a better distribution of funds, or at least a redistribution of funds. For some other modules, costs have increased overall. But if we're looking at, for example, in Sweden, the episode-based bundle payment, the overall cost has increased linked to an increase in volume. But then if we're looking at single episode, it seems that per episode the cost has decreased, so maybe an improvement of efficiency. And finally, maybe on unintended consequences and negative consequences, there is really a point about administrative burden that is important. Value-based payments models are time and effort consuming, both for payers and providers. It's on the two sides. And then on that question of maybe gamification and negative selection of patients that is often feared, here it seems that it really requires a careful design where the risk adjustment formula needs to really be adapted to the local context and to be a good prediction of the actual costs.
Beatrice, thank you so much. That's really super helpful. I have a question for you, and that's a more kind of strategic question. You mentioned these payment mechanisms. There are countries which are dealing with it for 20 years. We heard here quite sophisticated reports and so on. And what I get from the panelists is the particular challenge is the implementation, actually. And I was wondering, is there an opportunity to learn from each other? Or is it too specific? Is it too institutionalized that the context of Italy, we cannot learn much for the context of Germany? Or do you see some commonalities where you could say these are a couple of key issues which should be taken into consideration when we implement value-based payment?
Well, I think there are always opportunities for learning from each other. I think it seemed that one maybe important learning from those was the fact that we should not overlook the effort it takes to generate and collect data and all of those. And I think it was already mentioned by Scott in his keynote that these models really requires adequate data for their design and also for their monitoring and therefore their success. But then maybe we can also learn from the process of indeed the implementation. And I think here there was also a lesson about maybe the co-creation and the importance of involving both payers and providers in this discussion and in the design of the payment so that it's actually adapted to the local context.
Thank you so much, Beatrice. And that brings me back to Italy again. And I think really talking a little bit about the governance would be really good, Also, I don't know, yesterday I saw a couple of colleagues from Agenas. Does Agenas as an agency plays a role in it? And if so, I could figure that, making the transmission between the national and the regional level could be quite interesting. Fill us a little bit in on the governance of innovating payment systems in Italy.
All right. There is a two-tier system. Obviously, we have a central government which is trying obviously to harmonize policies across regions when it comes to introducing what we call value-based mechanism. Specifically, the role of the central government is to making sure that all the regions comply with what we call an essential level of care. So the fact that when they deliver care for their citizens, there's a minimum requirements in terms of value that need to be provided to the citizens. This is done through the dashboard that each region is responsible for. In the dashboard, you have things like, the application of certain clinical protocols, you have waiting times, you have accessibility in terms of proximity and the organization of the network, you have readmissions, you have, so the typical measure that help you to understand whether you're providing good care in terms of quality. Not really outcomes because they're very difficult to measure, but proxy of them, and that's quite interesting. The other things that the central government is trying to do is also to push forward some innovation in terms of payment mechanism for chronic patients, because chronic patients is the issue for the system. And in that sense, they're pushing the regions to adopt what you will call bundled payment mechanism. An example that I said before of putting together outpatient procedures which could be combined in one single payment, or the extended DRG. These are often they are born as an initiative in one region, but then they're quickly taken by the central government and try to be extended. AGENAS is the national agency which actually support the Minister of Health as a technical agency, trying to spreading to the system what are the best practices that are coming out from the regions. And that's the central try. Quickly at the local level, or the regional level, which is the regional level, we have quite a lot of difference, or rather say, in the capacity the regions has. That actually is because, as you can understand, you have a regional health departments running the regional health system, and the capability and the capacity of the regional departments might be different. So there are some that are strong history, they have strong background, they have a strong capacity in terms of professionals which are leading better. And just to give an example, for instance, in Lombardy regions, where there was Lombardy is 1/5 of Italy, 1/6 of Italy in terms of size. So we're talking about 10 million of inhabitants, so larger than many countries. At a certain point, we had a very strong group of people, and they developed a system. They were called chronic related groups. So they tried to adapt the DRG to the chronic patients. It was an experiment that lasted almost 10 years. Very difficult, complex, but the idea was actually we're going to take bundle payment, and we put that into the system. So there was a good experiment. It was so complex from a technical viewpoint because innovations, for a number of reasons, once you put up a system like that, the problem is that what's going to happen when you have a new medicine, a new technology, every year you have to do a sort of a revision, so it becomes so complicated in terms of effort. Then we decided this is okay. We'll go for a small size bundle payment situation, but we'll move in that direction.
Federico, I understand that
yes,
Italy is quite an innovative lab in this regard, and regions learn from each other. But do you also look beyond? Do you look also at other countries systematically to see what are they doing? Is it something for us? Should we adopt this? Shall we discuss it?
Yes, certainly. I think it's necessary that we have more and more contamination across countries. I personally lead sometimes study tour in other countries. I've been bringing people in Spain and in Sweden and Stockholm with Pamela, and also we're going to Portugal. So I think there's a lot to learn from each other. One other thing, for instance, with which we're trying to work a lot is value-based procurement, because that's another frontier on which we're trying to work. And value-based procurement is really easier than actually value-based payment to some extent, because then you can have a certain, you can frame better the problem. But the answer is yes.
This is actually almost a perfect bridge for asking Pamela about the integration of non-health objective into pay-for-performance value-based payment system, and it's about sustainability. And I'm saying this because, in Europe, and we had in Rome actually the EHMA conference, which was very much on sustainability and climate, and we were discussing it. Now, how do we get this into the system, the sustainable purchase, but now we're talking about sustainable value-based payment system. Please, Pamela, fill us in.
Yes, I was sharing this morning some of the research that I'm doing currently, where we're looking at how healthcare organizations respond to climate goals that are tied to financial incentives. So that's also very regional. Also, Sweden has 21 regions. Basically, they all decide on their own financing model. But in the region where I work, every hospital has 2% of their reimbursement is based on the achievement of certain targets, and 0.5% of that 2% is based on climate and sustainability goals. So I've been looking at how managers react to those goals. And I think at this point, very early on in this research, my conclusion would be that the use of these climate-related and sustainability goals make these issues visible in healthcare organizations when they are otherwise become, down prioritized because of other priorities and other goals. There's also a risk, though, that they incentivize the so-called low-hanging fruits. I see a lot of that in management meetings and board meetings. When you have performance-related goals, the first question is how do we make sure that we achieve them, not how do we make sure that they actually have an impact on value or health or climate. So that would be the drawback, but I guess that's a way to start.
It's very interesting because we were just discussing over lunchtime, why is it possible that in Catalonia so many hospitals are actually going for a sustainable process? But for example, in my country, we have all the policies which are necessary, all the commitments, but nobody's doing anything because they say we can't do this, we can't afford it, And maybe, payment mechanisms are one element in this. I could listen to you all afternoon, but we also want to hear from our audience, and this is now the opportunity that our audience is putting questions to the panel, and my colleague Nathan Schuftan and myself, we will walk the stairs and collect questions from you, and please, somebody voluntary or I will... Yes, wonderful, you're the icebreaker. Introduce yourself and fire away your question.
So I'm Luc Baltz, a PhD student at Tilburg University. And so question to you all, basically, you mentioned that value-based pricing or costing can increase the cost of care or increase the time spent in care. But what if you define value as time saving? Would that be possible? And if so, what would be the consequences?
Thank you so much. And we collect 3 questions before we get back to you, but I think it's very important also to clarify between efficiency and cost containment, and these are very different things. So the next question, please. Yes, I'm coming up to you.
Hi, Alexandra Erling, PhD candidate from Stockholm School of Economics. I'm curious to hear, have you seen or is there any research on the influence on, for instance, nurse retention when we think about these value-based payment systems? Thank you.
Thank you so much. So we have the next generation being very curious. More show of hands, at least one more. Olivier, I can see you are very nervous.
I forgot my hat, I couldn't hide, but no, thanks very much for your presentation, very inspiring. In France here we are talking very much about territorial approach to performance, that is multi-agent approach. I was wondering whether there is some thinking and some innovation into looking at something which is more geared to a territorial population, performance and value for this population as opposed to individual agents, if that makes sense.
Okay, you don't need to respond to each of the questions, just the one where you feel best suited, but you can also respond to 2. Beatrice, would you like to start? Is that okay? Or Scott? Scott, you start.
What if you define value as time saving? That's part of the problem, right? Is that this is a tool that can be used for many things. And it's easy to save time and deliver worst value care. And it's also easy to waste time, which is not value. So these tools will often work well to achieve the intended objective, but the intended objective still matters. And the unintended objectives can sometimes be to improve quality of care at a higher cost. And equally, the unintended objectives can sometimes be, for example, to stress out the workforce by giving them too much IT. I don't think there's much research directly on the link from payment systems to workforce. What I think there is there's a lot of research on what payment systems do to organizations and then what organizations do to workforce.
there are a few qualitative studies on the effects of value-based reimbursement models in Sweden, both tied to specialist care and primary care. So they, of course, they're qualitative, but there is some research, and it basically shows that they are they look at as I said before, it's complicated because the reimbursement model was part also of a larger reform that was very much incentivizing competition. So when you evaluate the effects of this reimbursement model, you can't take them away from the context in which they're implemented, but I can share some references.
Federico?
I not really answer for any of the questions, but I can just add a point. I think that if you have an organization which can boast that they are using value-based or a system which is using value-based approaches to funding or financing, I think could be more attractive, right, for especially the young generation and for the necessity we all have to belong to organization in which we can identify because we share the same values. So if that actually is something that can help actually to attract better people to the workforce or the future for the future of our system and the retention, I think it's worth to do it. Yes.
I think that's definitely true, at least for the climate, also for the sustainability aspects. When I talk to managers, I mean, they are convinced that, you know, the new generations of healthcare professionals may actually matter for them in what kind of organization you work and how sustainable you are. Yeah. So I think that can make.
And if I can add one of the last things about nursing. Nurses are very, very sensitive about starting to measuring the outcomes of what they do in a hospital, and eventually if some of the funding could be also connected to the outcomes of the nursing activity, I think that could be actually a plus for any organizational system. They're moving in that direction quickly, and I think we need to support the movement.
Okay. Has somebody addressed Olivier's question, actually? Not quite?
I can try to address this question. Okay. On the territorial approach, I think that actually the Swedish system of risk-adjusted capitation in primary healthcare is really interesting because there are 21 regions, there are 21 systems basically. But so they're working with, so every region is deciding on the risk-adjusting formula, so it's really adapted to the local context and maybe sparking a bit more of co-creation because it is regional. However, they are working with national indicators that have been developed at the national level, and so also the combination of those two is, I think, particularly interesting and maybe inspiring.
Excellent answer. Very good.
I can also add that in our system, territorial approach has been always there since 1978 when we established the NHS, and we had since that local health authorities in charge of populations in a geographical area. And we still think actually it's really the core value of the system, because when you have someone in charge of guarantee that in that population you have the right access and the right attention to preventive activity, curative rehabilitation, all the, let's say, integrated system necessary to provide maintenance of the health of that populations with one single authority coordinating the majority of providers, either public or private accredited. I think that's a plus and something that's worth actually to look for.
Very good, thank you. We have the opportunity for another three questions. I can see already there, and I can see a second hand, Nathan, further down the staircase.
I'm Eric Troquet. I'm full professor at University of Quebec in Ottawa in Canada. My question is about the performance, because we are talking about the value-based performance. How do you define the performance? Because it could be very complex to define the performance, to evaluate the value-based performance, because you could have to evaluate the performance based on demand, based on supply, based on stocks, and so on, and education. So I would like just to have, for your study, how do you define the performance when you evaluate the value-based performance? Thank you.
So, more hands, please. Oh, yeah, of course. Oh, there are two.
Yeah, maybe very connected. Olena Chernenko, Ukraine. The most difficult part in value-based payments, as for me, is the thing that if we estimate outcomes Generally, for example, bundled payments, these outcomes are influenced not only by doctor's work or hospital management, but also for patient actions or inactions. And they may be intended or unintended, or sometimes even beyond the consciousness. How can you reflect this? Because it's true for every medical service, especially if we consider them like a complex clinical case. And they are very different, very complex, different in every medical specialty. Connected with previous question.
Nathan, there was another gentleman up there.
Brent Opmeer from Freelance in the Netherlands. I think from a health economic perspective, an important question is whether you consider a closed budget for your healthcare or an open budget. So if there's a closed budget, you would like to maximize value for that budget, and if it's an open budget, then you can produce more value, but then your costs in total will increase. Could one of the panel reflect on whether you consider a closed budget or an open budget?
Very good. And Nathan, there's one more up there, the lady at the, yes, and that's the last one we can take at the moment.
Hello, I'm Anastasia. I'm working at the National Board of Health and Welfare in Sweden. My question is, in these models we talk about value of care, high value of care. Do we talk at all about low value care? Because we know all the numbers that the healthcare systems do a lot of things that don't come to value to patients. And I was wondering if someone has looked at financial incentives for decreasing or de-implementing low value care.
Thank you so much. So, who wants to go first?
I can maybe start with the question on how to measure the performance about our study. In our study, it really depends on the objective, how you would define that performance. And so what we looked at the outcome and the performance per model. And I think that also highlights again the importance of the efforts in data generation and data collection, and looking at what are those indicators and what is the available data to be able to measure that performance. And that's really something that, again, shouldn't be overlooked when someone wants to design a value-based payment, because this is really at the core, indeed, of the payment.
Maybe I can just build on this and try to ask the question about the outcomes. And as far as I can tell from my experience, is that the examples of outcomes, value-based reimbursement model that account for outcomes are only tied to very well-defined clinical conditions. I haven't seen examples of reimbursement models tied to outcomes for more complex and chronic conditions. At least when I looked at the literature, it might have changed. So for instance, the hip and knee replacement, you have the reimbursement tied to complications. And already there could be questions of whether the complications are associated to the surgery or not. But those are the examples that I have seen. I don't know if you've seen.
Yeah. I think that's why there's a limit. Look at the percentages that have been getting quoted. 1%, 0.5%, 2%. You could say these are good value policies if they get any reaction on the margins from these small numbers. But equally, if you even do a fairly basic thing like, management of diabetes or complications from simple surgeries, if you get it wrong, you can do a lot of damage. And so we see very few on the complex things. We see very few in areas like mental health that have had a lot of impact, because otherwise you risk destabilizing small organizations if you get your adjustment wrong. And it's very easy to get the adjustment wrong. The other quick thing I'd say is, notice how about 2/3 of these questions have been, we all agree on value, we like value, and we're actually fighting about what is value.
Has somebody addressed the gentleman's question on the open and closed budgets?
Yeah, I can do that. Now, quickly, how to identify performance? I think it's a matter of multidimensional systems. I mean, there's nothing new in that. You can have obviously different views, perspectives. You need to be obviously multidimensional when you look at performance in order to balance the different attention that otherwise would be put. You know, what you measure really matters for the organization, so you have to be careful about deciding what to measure. Second, outcomes. We have two movements, rather say, in Italy. When we're not able to measure the final outcomes because they're also influenced by the activity of the patient itself, we use process measures, so we use proxy. We say if certain things have been done and according to the clinical protocols and so on. But in some situations, for instance, when it comes to drugs therapy, when you can really isolate the effect of the drug therapy in terms of outcomes, then we're moving into that kind of measuring, because that you really have a clear, once you have obviously control for adherence and where the patients have been complying with the therapy. Closed budget, open budget, our experience, closed budget all the time, never open budget. Open budget are very, very problematic to control. There's a lot of over-treatment that goes on. There can be a number of, let's say...
My kids have a different view on this.
Yeah, you need, obviously, if you do closed budget, you need to control for under-treatment, and you need to obviously have a system to measure exactly what happened within the closed budget. And last, low-value care. We have this experience in our system. We identified a number of procedures which we believe in the DRG system and also for the local health organization funded by capitation that should not be anymore done, and they are not paid by the system in the DRG, or there has a penalty in the capitation if you perform those procedures. It's quite a long list, 40 to 50 every year is updated by the regions in order to make sure that also there's a transition from, for instance, usual care today to outpatient. So we also use the funding system to move behaviors of professionals from one let's say, focus to another one.
Federico, thank you so much. Great response. And before we close the session, now comes the surprise for the panelists. I would like to have every panelist giving us a takeaway message, very briefly, you know, just 1 or 2 sentences. Who's smiling the most? Is it you, Pamela, or Beatrice? It's you, Pamela. You start.
We said that in Sweden we are very happy about reimbursement models, so I was obliged to smile. No, I don't know, really. I quote one of my favorites, maybe. All systems are perfectly designed to achieve the results they get. So, do you want to increase...
Perfect.
You know what
I guess it would be that there are many ways of designing those modules, but those modules are not new, and there are definitely some very interesting experiences to learn from each other. And I'm very happy for this panel, and I hope that you will find it inspiring as well.
Excellent. Thank you so much, Beatrice.
Good tool. Be careful.
And stay simple, because that actually really makes things work better for professionals. And on the other side, you have people that actually are involved in complex activity. They've been studying and working, so you have to engage them. If you make really complex procedures in terms of funding and things that actually make bureaucratic work for them, they're gonna really, really, really hate you a lot.
Thank you so much. A big show of hands for these wonderful panelists. And thank you so much for playing along in the question and answers, and have a great rest of the conference.